Hi, this is Kendrick Johnson with themedschool.com. Today we're going to be talking about diabetes. We're going to cover both type 1 and type 2 diabetes, but type 2 will probably be the focus of this video. And it's going to be focused on information that's most relevant to medical students in their clinical years and other people trying to learn clinical medicine. So why is this an important topic? There's about 285 million people with diabetes in the world, and most of those are type 2. About 90% are type 2. And it's not a fun disease to have. There's a lot of complications associated with diabetes, and many of these complications contribute to some of the biggest killers that we have in medicine. So heart attacks, strokes, kidney failure, blindness, infections, neuropathy, and amputations are all some of the serious complications of diabetes. I included this diagram of the guy with all the diabetes complications here to the right, mostly just because I spent a long time making that a couple of years ago, and so I thought I'd throw it in here. So the pathology of diabetes is not real well understood. But as you know, it's called diabetes mellitus, and it is called mellitus because of the increased blood sugar. And that can be due to either insulin resistance or insulin deficiency. And genetics and lifestyle play a big role in type 1 diabetes, or type 2 diabetes, and autoimmune disease is the biggest factor in type 1 diabetes. So in either case, we are impairing either the action or the production of insulin, and insulin is the enzyme or the protein that tells the cells to take in glucose. So if it's not working, then the glucose is not being taken into the cells. You also get inappropriate insulin release in diabetes, which means we are just the pancreas is not functioning properly. So the high blood sugar has complications of its own. It leads to hypertension and the production of what we call advanced glycosylation products. So glycosylation is the addition of a sugar to a protein in most cases. And a lot of these glycosylation products or advanced glycosylation products can't be broken down. And so they deposit often in the endothelium and in other spots where they're not supposed to be, and they can cause inflammation as well as just obstruction. And so these are the things that contribute to the main complications that we'll talk about in a second. So type 1 we classically think of as being the childhood diabetes. It can happen at any time during life, and it can be caused or can have be initiated by different factors. But most often you're going to see it in children. And these kids, if we catch them early, we're going to see them with the polyphagia, polydipsia, polyuria. They're going to have some weight loss, and some of them are going to be coming in with DKA, which we hope we can avoid. So DKA, diabetic ketoacidosis, is a condition. I won't talk about the pathology here because we'll probably do another video just on DKA at some point. But these kids often come in with Kussmaul respiration, which is these long, slow, deep breaths. They have abdominal pain. They're dehydrated. They have an anion gut acidosis. In the labs, we're going to see ketones. We're going to see lots of potassium and we're going to see our hyperglycemia. Sometimes these numbers are in the 700s, 800s, even the thousands. And mucosinusitis, I don't know a lot about, but this is a potentially life-threatening condition that is often associated with DKA. So the type 2s we're going to see differently. People are going to come in with an adult onset. Often they have a family history of type 2 diabetes, and they're going to have that same polyuria, polydipsia, what was the other one? Anyway, they're going to be dehydrated. They're going to be drinking a lot and peeing a lot. And in some of the cases, as type 2 is begun, they are going to have some weight loss and fatigue, infections, and then the vascular disease. A lot of these will probably catch before we see the vascular disease, but these people can have stroke, coronary artery disease, nephritis, retinopathy, and also neuropathy is a big symptom of type 2. So I mentioned that hopefully we're going to catch these people in screening. Screening has been a little bit debated on whether or not it's cost effective, but the main powers that be, like the ADA, are recommending screening for anybody with 2 risk factors. So these are people over 45, overweight, sedentary, of ethnic groups, especially Native Americans and African Americans, and Latin Americans. If you have a history of gestational diabetes or polycystic ovarian syndrome, those are all risk factors for type 2 diabetes. I left out hypertension and a couple others. So this is a huge chunk of the population. I mean, if just people overweight alone, that's a good more than a third of the population and rising. And sedentary lifestyle, you add that to it, and you've got most of your patients are probably going to meet 2 risk factors for screening for diabetes. So the diagnosis is made by any random glucose over 200, or 2 fasting glucoses over 125. So a lot of times you'll just be ordering like the complete metabolic panel that includes fasting glucose. And if you see one of these over 100, then you might run either the 2-hour glucose tolerance test or you'll do an A1C. This is kind of a new thing. The hemoglobin A1C over 6.5 was just accepted in 2009 as an acceptable screening tool and diagnostic tool for type 2 diabetes. So this is an important thing to do so we can start treatment and prevent some of the bad things that happen with diabetes. So in type 2 diabetes, there's a huge lifestyle component that's going to have a major effect on the progression of the disease. Much of type 2 diabetes can be avoided or at least controlled with non-pharmacological lifestyle type changes. So a healthy diet, exercise. In some cases, bariatric surgery might be warranted if people are unable to lose weight otherwise. But the official recommendations are today to start metformin along with the lifestyle changes as a first-line therapy. So even though a lot of people probably could be managed by lifestyle changes, I think my theory is that the reality of it is that a lot of people just aren't changing their lifestyle, whether it be their own lack of willpower or the fact that their doctor doesn't have enough time to help them with it. But either way, a lot of these people are not getting controlled just by lifestyle changes. So with a new diagnosis of diabetes, the recommendation is to start metformin along with dietary exercise counseling. So that's your first line. You're going to follow up in a few months, and if you are not able to get their hemoglobin A1C under 7, then you're going to be adding another agent. So a lot of times you're going to be adding glipizide or glyburide, one of the sulfonylureas. These act by increasing insulin secretion. You also got your pioglitazone, rosiglitazone, which are your thiazolidinediones, and they increase the sensitivity of the cells to insulin. So if none of these, or a combination of all these, are not giving you the control that you need, then you're going to have to use insulin. This you might have to use insulin also in cases where people are just not very compliant with their medications as well. Or of course, if it's a type 1 patient, then we skip over the metformin, sulfonylureas, etc., and go straight to the insulin, because those others are dependent on having some insulin secretion, or some insulin effectiveness. So ACE inhibitors are also important, not for controlling the blood sugar, but for controlling some of the adverse effects of the hyperglycemia. Mainly, most importantly, they are there to protect your kidneys. There's some debate over how these exactly protect your kidneys, but it's understood that they prevent remodeling of the kidneys, and therefore prevent kidney failure. So going back to type 1, sorry that this is kind of crammed in here like this, but to type 1 with your DKA treatment. And by the way, you can have DKAs with type 2 as well, but it's much more common in type 1. So if a patient comes in with DKA, the major treatment is fluids. That's the biggest thing that has to be done, is to get fluids in there. Potassium and insulin, and potentially glucose. Now, the glucose probably sounds like it's a little bit counterintuitive, especially if you're adding insulin and glucose at the same time. But the insulin that we're giving is actually not to decrease the blood sugar, but to prevent ketogenesis. So the glucose is given at the same time as the insulin to keep blood sugars normal once they are normal, and then the insulin is there to prevent further ketone production. So back to type 2, well, mainly type 2, I guess this could apply to both. We want to prevent the complications of diabetes, and so with a regular diabetic checkup, you want to have an eye exam, a foot exam, you want to do a microalbumin screen, and address coronary artery disease. So the eye exam, I'm not going to go over here, because I personally am probably just going to send them to an ophthalmologist every year. They need a dilated eye exam, and I probably won't do that in a primary care setting. But the foot exam you'll do probably in a primary care setting. So you want to look at the foot, make sure there's no ulcers and calluses. talk to them about the history of claudication, check their pulses, do an ABI, ankle brachial index, to check for vascular disease. The monofilament test, I just figured out recently that I've been doing it wrong. These are the points that I've got here on the kind of strange foot picture. It looks like whoever took this picture is probably taking it of their own foot. So if anybody wants to take a really nice picture of their foot and send it to me, then I'll use that one instead. But these points here, one on the big toe, one on the little toe, 3 across the ball of the foot, and then 1 on the heel. Those are the points that you want to check with your monofilament. And then to diagnose neuropathy, you use monofilament plus vibration or plus some other sensory test. You want to talk to them about their feet care. They need to wear shoes. They need to test their water temperature, trim their nails, keep them clean, and also you want to do a microalbuminuria screen. So get that urine sample and make sure they're on the ACE inhibitors, and just watch their A1C levels really carefully. So if the coronary artery disease screen, this is one that a lot of doctors are just doing with any of their diabetic patients. The official recommendations are that you want to do a screen for any sedentary diabetic who's planning on starting a new exercise plan. So these people need to get a stress test. And then with all of them, you want to talk about the risk factors. So obesity and hypertension, those are all part of the metabolic syndrome that leads to coronary artery disease. Keep their hypertension under control. Watch their lipids. Most of these you want to keep under 100 on their LDL levels. You can do that with lifestyle and statins mainly. Get them to stop smoking. I can't remember why this asterisk is here on the smoking, but I think it is. I don't know. Maybe it was just important. I can't remember why I put it there. Aspirin has a little bit of a question mark by it, but most people are still recommending aspirin. Metformin has some anti-inflammatory properties also that are shown to help with coronary artery disease. Exercise, and then just, again, the glycemic control. These are the risk factors that I just talked about. I meant to take this slide out. And these are where the artwork comes from for this video. Please send me your comments on what you think I can do better here, important information that I've left out, or information that I got wrong. Again, it's Kendrick with themedschool.com. You can email me at kendrick at themedschool.com, or you can leave a comment below. Thanks.